Welcome to Bay Area Psychology. Over the centuries, humans, like most other species, have developed a biological clock, or a group of brain cells that determines when you feel sleepy, when you feel alert, when hormones are released, and more. Usually, our internal clock is synchronized with the clock on the wall, and everything runs smoothly. But what happens if your sleep schedule is midnight to 7, but your internal clock is set for peak alertness at 3 a.m.? Maybe you're one of the 15 to 30% of the adult population that regularly struggles with insomnia. Tonight, we are fortunate to have Dr. Rafael Paena from the Stanford Sleep Clinic here to explain sleep disorders as well as the emotional signs of interrupted sleep. Welcome. I want to thank you for joining us, and I have a feeling I mangled your name, so I'm going to try that again, actually. It's Dr. Rafael Pelayo.
You do the Pelayo or Pelayo, either way, it's all the same.
I do apologize for that.
Okay.
Thank you for joining us.
Thank you.
This particular topic is of interest to a great many people that I know personally. I know I've certainly had occasional difficult night's sleep myself. And you are with the Stanford Sleep Disorders Clinic. Now, this clinic's been around for quite a while, hasn't it?
Yeah, it's the oldest sleep disorders clinic in the world. It opened in 1970.
Okay. And you yourself have been there since, you said, 1993?
That's right,
okay.
2.5 years.
Okay, so this is a real specialty for you.
Yeah.
Okay. What attracted you to working with sleep disorders?
That's what I wanted to do when I got to medical school. It was the one field I was more curious about. When I went to medical school, I was thinking maybe doing something along with the mind and behavior, psychiatry perhaps. But when I was an undergraduate, I was working in a nephrology lab working with rats and kidney problems. And I was kind of curious about sleep, and I asked the graduate students, what do we know about sleep and who does the research on sleep? And they kind of laughed and said, nobody really does any work on sleep. So I said, oh, someday I'll do some work on sleep, I told them. Okay. And they kind of laughed it off. So when I got to medical school, I was fortunate. I saw a sign saying, quiet patients sleeping. And it was a sleep disorders clinic for that hospital. Okay. So I volunteered. And that's how it started.
Well, and you were mentioning before the show that while I had quoted a statistic of 15 to 30%, you were actually saying that there's been a more recent Gallup poll about how often people are affected by a sleep disorder.
Sure. If you ask people if they've ever had a bad night of sleep, it's universal. About 97–98% of the people have had poor sleep at some point in their lives. And it's very important to remember that. Now, as far as chronic sleep disorders, the thought is that maybe only 9 or 10% of people have chronic insomnia. Okay. General complaints about their sleep, the most recent Gallup poll showed that over 50% of the people in the United States have some concern about their sleep.
Okay. So 50% of us probably struggle at one point or another with getting a good night's sleep. And there's, I'm sure, a lot of factors that can affect that. I have put together a series of questions which has been used in Richard Coleman's book, Wide Awake at 3 a.m., to take a look at issues to consider when diagnosing insomnia. Let's take a look at the first one.
Sure.
How long have you had your sleep problem? Is this, why is it important, the length of time when you're doing a diagnosis with somebody?
Well, in general medicine, you always want to know if something's acute or chronic or subacute. And the treatment plans will change. For example, in insomnia, if you have an acute insomnia, short-term insomnia, I might prescribe sleeping pills. If you've had insomnia more than, let's say, 6 months, there's really no role for sleeping pills. So it's very important to know the duration of the problem.
Okay. And so sleeping pills, I mean, I have heard some different feelings about that. There's different controversy about sleeping pills. So you're saying that they're really used for short-term use?
That's the only thing they've ever been approved by the FDA for.
Okay.
If you look in the physician's desk reference, the PDR, it says for short-term use of for short-term insomnia.
Okay.
They were never meant to be used for years at a time on a single person.
Okay, because I have certainly, of course, one of my specialties is addiction and recovery, and I've certainly encountered clients who have been taking different sleep medications for years and years. Okay.
That's inappropriate.
Can that actually cause a sleep disorder?
Almost every sleeping pill has insomnia as a side effect when used on a long-term basis.
Okay, so the longer I take it, the more I may need to take.
Yeah, also you develop tolerance, and people are less the medication becomes less effective. And then if you stop taking it, you get something called rebound insomnia, where the insomnia is worse for 1 or 2 days. And most of my patients who've been on sleeping pills try to stop on their own. After 1 or 2 nights of not sleeping well, on the 3rd night they have to take the pill.
Okay.
And what I actually tell them to do is just wait it out another 3 to maybe 5 days before that rebound insomnia goes away. But it's very tough.
So really then it's probably better for people to decrease their sleeping pills slowly under a doctor's care rather than just stop taking them.
Yeah, if you've been on sleeping pills for on a long-term basis, it has to be tapered off.
Okay, all right. That's interesting and it's helpful to know. The second question that came up on our questionnaire was asking a patient about depression. Can you tell us why depression might be important?
There have been several surveys that show that about half the people with chronic insomnia have depression on top of it. Well, some surveys say half the people with chronic insomnia have some type of psychiatric problem, and of those people, half of them have depression. So either a half to a fourth of all patients with chronic insomnia have some type of psychiatric problem also going on at the same time.
That's important to know. I know that with the clients I treat, one of the key signs of clinical depression has to do with changes in sleep, either sleeping more, sometimes 13, 14 hours a day, or what's called early morning awakening.
That's right.
And I guess that's where people wake up periodically or wake up at 3 and can't go back to sleep.
That's right.
Okay. And now, I know that it's common for people to be preoccupied about something specific, maybe worried about their job or that sort of thing, and feel like they're not getting enough sleep. But then I've also seen studies that show that, I guess in places like your clinic, when you actually measure how much sleep someone's getting, often they're getting more than they're self-reporting. Why is that?
Well, there's a few different things. People with chronic insomnia often have along with their problem something called sleep state misperception. They swear they're awake when in fact they're sleeping, and their bed partners will tell them, "I knew you looked like you were asleep." Says, "No, I didn't sleep at all," because the sleep is no longer refreshing. Or if they are sleeping, it's in what we refer to as light sleep or stage 1 sleep. And one of the characteristics of stage 1 sleep is that you deny being asleep while you're in it.
Okay.
So there are a lot of different things. And the point to point out, first of all, is that insomnia is not a disease. It's a complaint. It's like saying fever. There are 84 different sleep disorders officially recognized, and there's several more that have been proposed. There's several different types of insomnia.
Okay, so just using insomnia as a general category really isn't going to be specific enough.
It's like saying pain.
Oh, like say, oh, okay, that's interesting. Okay, let's take a look at the next question in our survey here. I know sometimes patients are asked, are you anxious going to sleep? Tell me about the role of anxiety for people. How does that keep us awake?
Okay, well, the fundamental question is, why do we sleep in the first place? Okay, and for whatever reason, our sleep is supposed to help restore our bodies and our mind to deal with the next day, and they protect us. Most of our predators, as an animal, are night hunters, so it makes sense for us to be asleep in the dark.
Okay.
And when you look at a monkey, monkeys, if you keep them in the dark, they stop moving. We have color vision. We hunt and gather. We can pick out the fruit. Okay, we hunt in groups. So we're supposed to be out during the day, and we're supposed to be sleeping at night.
Okay.
But a sleeping animal is very vulnerable to attack. So if you're worried about anything, the brain's natural reaction is stay awake and take care of the problem. So at one point we used to be worried about somebody breaking into our homes or our personal safety. But if you're worried about the bills or something you forgot to do, it's all the same to the brain. Same neurotransmitters are putting you in a vigilant mode. And as long as you're vigilant, you're not going to sleep. And the worst thing to be worried about is being anxious that you're not going to sleep. Yeah,
because I know for myself what a vicious cycle that can be, which is, oh God, is tonight going to be another night where I'm not going to sleep well, and then you wind up ruminating about that. Yeah. In fact, I know ruminating in general or thinking about something over and over again is common for a lot of psychiatric dilemmas or disorders.
That's right. That's one of the things we go over with our patients. There's one particular, the most common form of chronic insomnia is referred to as psychophysiological insomnia. And that implies that there is a biological predisposition to insomnia. For example, certain personality types tend to get insomnia, along with a psychological component. Psychological component is what's referred to as a somaticized tension. That's at times of increased stress. Just the simple thought of going to bed makes you awake. And what you watch for is, you'll ask somebody is, as you're about to go to bed at night, you feel drowsy, but when you get to the bedroom, you suddenly feel more awake. If that happens to you, you have psychophysiological insomnia. Or if you can fall asleep easier when you're not in your bed, like for example, as a passenger in a car, okay, or when you don't have the tension of wanting to sleep or forcing yourself to sleep.
Okay.
It's a common feature to that.
Okay, so in fact, it almost sounds like we can begin to have I don't know if this is correct, but almost a phobic reaction about our own bedrooms.
Oh, sure.
Which is associating that with not being able to sleep, which is that why we're encouraged to not work in our bedrooms, not do things other than sleep or have sex in the bedroom?
That's right.
Because everything else then could
You want to
preoccupy us.
basically, see, think of sleep for the brain like oxygen for the lungs and food for the stomach. The brain prefers to sleep rather than, for example, breathe. When given a choice, the brain will sleep instead of breathing if it has to choose between the two of them. So sleep is that important. And all animals pretty much sleep. So it's whatever sleep is for, it has to be very important. So one of the things that will happen is that if you have bad sleep, you can try to adapt your body to sleep under any circumstances as long as you learn when to sleep.
Okay.
We learn when we can sleep. If you look at a baby, a newborn will sleep anywhere. Throw it on the floor, it'll sleep just fine. People talk loud, the baby doesn't flinch, it keeps sleeping. But as an adult, you may be very sleepy. If you have to lie down on the highway, you won't sleep.
Okay.
You learn where you can sleep. So what we try to do with people is if they've had chronic insomnia, they've no longer look forward to going to bed. They've lost that pleasure of being in their bedroom, which most good sleepers have. They can't wait to get into their beds.
Right.
So what we try to do is recreate that for them, and we try to force have the patients force their own bodies to accept their beds again by not doing anything awake in bed.
Okay.
So that's what we try to do with them.
Okay.
And if you're going to sleep at any other time, you have to sleep in your bed. Don't sleep anywhere else except in your bed.
Okay. So that kind of breaks that cycle of falling asleep on the couch in front of the television.
That's right.
For example. Okay. That's interesting. How do you know that, given a choice, the brain would rather sleep?
Instead of breathing?
Yeah, instead of breathing.
Oh, that's for example, in obstructive sleep apnea syndrome, that's exactly what occurs. People, when they are sleeping, the muscles are relaxing, and they relax to the point that their throat will collapse.
Okay.
So what occurs, and it occurs hundreds of times during the night, is as they fall asleep, they stop breathing because their throat is collapsing.
Okay.
And if they stop breathing after a while, they'll wake themselves up briefly, but instead of waking up completely, they'll try to get back into sleep.
Okay, and that's what we call sleep apnea. We'll talk a little bit more
Yeah.
about that after our break.
Sure.
Stay tuned and do stay awake. When we return, we'll look at more ways to get restful sleep.
Reasons people don't get enough sleep. Sometimes there are physical problems, like sleep apnea. People with this disorder repeatedly stop breathing at night, sometimes for 10 to 60 seconds at a time. The problem can be with the throat muscles or with the part of the brain that tells us to breathe.
When you wake up, you can look at the clock and you say, I've been in bed 8, 10, 12 hours, but I feel lousy.
Restless leg syndrome, or RLS, can also interrupt sleep. RLS patients feel a constant